Hi, welcome everyone to the last Journal Club webinar of this season. We're going to have Dr. Budh, NICU Fellow from the University of Buffalo, present on the TORPIDO 3060 trial. To start off, I'll introduce our guests, mentors. Dr. Julie Wei is a professor and neonatologist in Australia and the inaugural chair of neonatology at Mater Mothers Hospital and Mater Research Institute in Brisbane, Australia, as well as a professor at the University of New South Wales in Sydney. She has extensive clinical and research expertise in resuscitation of sick newborns and has authored more than 190 scientific papers and mentored more than 70 students and neonatal trainees. She leads an international resuscitation research group that has influenced national and global neonatal resuscitation guidelines, and importantly is the chief investigator on the NHMRC-funded TORPIDO 3060 trial, the subject of today's webinar, and which represents the largest randomized trial of initial oxygen concentration for resuscitation of extremely preterm infants. So welcome, Dr. Wei, and thank you for joining us early in the morning from Australia. Our second guest mentor is Dr. Vishal Kapadia. He is an associate professor of neonatal-perinatal medicine at UT Southwestern Medical Center in Dallas, Texas, where he is an NIH-funded physician scientist with clinical research expertise in fetal and neonatal transition and neonatal resuscitation. He co-chairs the American Academy of Pediatrics Neonatal Resuscitation Program Steering Committee and contributes to resuscitation guideline development for both the American Heart Association and the International Liaison Committee on Resuscitation. As a founding member and the UT Southwest site PI of the Delivery Room Intervention and Evaluation, or DRIVE network, he's also been a central figure in advancing multi-center delivery room research. He's also currently the PI for OptiStart, a multi-center randomized control trial designed to identify optimal oxygen saturation targets for preterm infants in the delivery room. So thank you for joining us, Dr. Kapadia. And I will say that all of the discussion here represents the opinions of the individuals present and do not reflect organizations that they may represent. For the audience, if you can keep yourself muted, if you have any comments or questions, put them in the chat, and at the end, we'll get to them if there's time. But thank you everyone for joining us, and Dr. Budh, you can get started.
Sounds good. Thank you. I'll start sharing. Are my slides visible to everyone?
Yep, looks good.
Yes.
Okay. Good evening, everyone. I am Hetal Budh. I'm a PGY4 at University at Buffalo. I am very grateful to the mentors, Dr. Mani, Dr. Julie Oy, Dr. Kapadia. I also want to thank American Academy of Pediatrics, Dr. King, and Dr. Jain for this opportunity. Today, we will discuss and critically appraise the TORPIDO 3060 randomized control trial. The objectives of today's presentation would be to review the evolution of oxygen use in neonatal resuscitation and the current evidence gaps. We will discuss the design and methodology of the TORPIDO 3060 trial. We'll also summarize the key findings and outcomes of this trial. We will critically appraise the trial, including its strengths, limitations, and clinical implications. And at the end, we'll discuss remaining uncertainties and future directions in oxygen targeting at birth. Use of oxygen for neonatal resuscitation. High oxygen exposure at birth can rapidly cause oxidative cellular injury. Reactive oxygen species overwhelm the immature neonatal antioxidant defenses. Oxidative stress is linked to lung, retinal, brain, cardiac, and renal injury, as well as increased mortality. 100% oxygen may also impair cerebral blood flow and delay spontaneous breathing. Preterm infants are particularly vulnerable due to pulmonary immaturity and limited antioxidant capacity. However, the optimal initial oxygen concentration during preterm resuscitation remains uncertain. Now, we'll understand the evolution of oxygen use during neonatal resuscitation. This image shows the use of oxygen during neonatal resuscitation. It shows the transition from the era of 100% oxygen use to a shift to lower oxygen. And understanding this transition and inclination of using oxygen saturation targets. However, the fundamental gaps in oxygen use and prevailing uncertainty still persists. For decades, neonatal resuscitation was largely performed using 100% oxygen. It was in the 1990s that some pioneering studies began comparing room air with 100% oxygen. Early landmark studies included the RAM-G study in 1993 and the RES-Air-2 trial in 1998, where they compared room air with 100% oxygen for resuscitation of term and near-term asphyxiated neonates. Subsequent meta-analysis by Davis et al. In 2004 and Sockstead in 2012 played a pivotal role in shifting the neonatal resuscitation practices away from the universal 100% use. These landmark trials demonstrated that room air was as effective as 100% oxygen. Meta-analysis later showed that there was a potential mortality benefit with the use of room air, and no proven long-term neurodevelopmental advantage of 100% oxygen use. These studies help shift neonatal resuscitation guidelines towards an initial room air resuscitation in term and near-term neonates. It was in 2010 that Dawson et al. Published a study that helped define the normal preductal saturation reference ranges during the first 10 minutes after birth in infants not requiring resuscitation. It included 468 infants with a mean gestation age of 38 plus minus 4 weeks and over 61,000 data points. The median saturation gradually increased after birth, reaching more than 90% at a median of 7.9 minutes. The preterm neonates demonstrated a slower rise in oxygen compared to the term infants. These findings help define the current delivery room SpO2 target ranges. Moving on to the era of recognition of harm with the exposure of oxygen. The studies by Vento et al. In 2001 and 2009 and Teterano in 2015 demonstrated that resuscitation with a higher oxygen concentration in both term and preterm neonates was associated with significantly increased oxidative stress biomarkers, and this included persistent elevation weeks after birth. These findings linked hyperoxia to pulmonary, retinal, neurologic, and systemic injury, particularly in extremely preterm neonates. The transition trend occurred with multiple meta-analyses and systematic reviews published in the last decade, and they showed no superiority of lower or higher initial FiO2 use. And oxygen needs to be carefully titrated to the saturation targets during preterm resuscitation. The TORPIDO trial, conducted in 2017, was a randomized trial in preterm neonates less than 32 weeks, and it compared room air with 100% oxygen use for initial resuscitation, with the primary outcome considered of death or major disability at 2 years. Oxygen was titrated to target saturations after birth. The study enrolled 287 infants and was stopped early due to loss of equipoise. In the post hoc analysis, it was found that infants less than 28 weeks had higher mortality with room air compared to 100% oxygen, 22% versus 6%. But as the results were underpowered, further research is required. A meta-analysis published in 2016, which included 8 randomized controlled trials with 504 extremely preterm neonates, compared low, that is less than or equal to 30% oxygen, versus high, more than or equal to 60% initial FiO2, and found no significant difference in mortality or major morbidities. However, the subgroup analysis was inconsistent. The masked trials suggested lower mortality with low FiO2, while the unmasked trials showed the opposite. And so this highlights the ongoing uncertainty in optimal oxygen targeting. Another meta-analysis published in JAMA Pediatrics in 2024 compared low, that is less than or equal to 30%, intermediate, 50 to 65%, and high, that is more than or equal to 90% initial FiO2 during resuscitation in preterm neonates, less than 32 weeks. It included 1,055 infants across all the studies from 2005 to 2019. It included 4 studies comparing low and intermediate oxygen FiO2 and 8 studies comparing low and high initial oxygen. High initial FiO2 was associated with lower mortality compared to low and intermediate. The authors concluded that though high initial FiO2 may reduce mortality in very preterm infants, the certainty of evidence remains low and further studies are needed. According to the ILCOR 2025 guidelines, for term and preterm and late preterm infants greater than or equal to 35 weeks, the recommendation is to start resuscitation with room air, and the routine use of 100% oxygen should be avoided, with oxygen to be titrated based on the pre-ductal saturation targets. For preterm neonates less than 32 weeks, the recommendation is to start resuscitation with at least 30% oxygen. However, this is a weak recommendation based on low certainty evidence. For 32 to 34 plus 6 week group, there is insufficient evidence for a specific starting oxygen concentration. And so most centers commonly begin with an FiO2 of 21 to 30% and titrate based on the saturation response. Based on all this evidence, the prevailing uncertainty still poses a very important question. What is the most effective initial FiO2 for resuscitation in preterm neonates? The TORPIDO trial was conducted to answer this question. Moving on, the TORPIDO 3060 randomized control trial was published in JAMA Pediatrics in December 2025. The research question that this study aims to answer was, does initiating resuscitation of extremely preterm neonates at a higher FiO2 of 60% reduce the risk of death or brain injury compared to an FiO2 of 30%? Here, I would like to
Dr.
request the
Budh,
mint.
yeah, great.
Yes.
I was going to do the same thing. I'd love to hear thoughts from Dr. Wei and Dr. Kapadia about particularly, I think after this great summary of sort of the journey that evidence has taken us on over the last few decades, ending up with the 30% versus 60% would be, is I think an important question.
Yes.
Who wants to go first, Vishal or me?
Julie, you go first.
Oh my God, you're such a gentleman. Well, so you're going to describe the longest ever running trial series in the whole universe of neonatology, I think. So our initial TORPIDO trial was funded for air, 21% or 100% oxygen. But when we received our funding in 2015, we were unable to get buy-in. So we had one side of the world saying there's no way, we can't use 21%, you'll kill every baby. And another side will say, oh, you can't use 100%, you'll kill every baby. So, and we learned from the first pilot study that was published in Pediatrics that it was almost impossible to recruit in a timely manner. So the first TORPIDO study that looked at 21 versus 100% could only recruit about 15% of our total sample size over 5 to 6 years. Getting informed consent for any resuscitation study is extremely difficult. So we wanted to do consent waiver or deferred consent for this research question of the next step. And we had a lived experience group. We had an amazing mom who came with us to the IRB for a presentation. And the only way we could get consent waiver for this question was to squeeze in the limits of the high and low oxygen levels to the boundaries that were recommended by the guidelines at that time. So not 21%, not 100%, but between 30 to 60%. So we'll talk about that later, but we were concerned that it was too narrow a margin, but that was the best we could do at that time.
If I can quickly add, I mean, Dr. Weiss, the history that you showed, Dr. Budh, shows how much pendulum has swung and how much we don't know, and still people harbor very strong opinions on what is the right thing to do. Also, want to congratulate Dr. Oi about showing remarkable persistence in answering this particular question and still planning
We
for
have
the
good friends,
study.
Vishal, isn't it? We have good
So
friends.
she's a role model in case if you are thinking about entering the research career.
Should I continue?
Yeah, you can keep going.
Go ahead.
Yeah. Okay. So moving on to the trial methodology and design, this was a randomized parallel study superiority trial conducted across 31 maternity hospitals in 6 countries, including Australia, India, Malaysia, Singapore, Spain, and the United States. The study received approval from both central and local institutional ethics committee at all the participating sites. The study used a dual consent strategy. In India and in most of the Indian centers and in Australia, a deferred or waiver of consent model was implemented. In contrast, a prospective return informed consent was obtained in all of the other centers wherever feasible. An independent data safety and monitoring committee conducted a pre-specified interim safety review after approximately 50% enrollment was completed. And this review followed the Hetal-Budh stopping boundaries, and it was recommended to continue the trial without any modifications. As for the blinding, clinicians and those assessing the outcomes were not blinded to group assignment. A question for the mentors I had over here is, due to the nature of the study, I do understand the DR clinicians not being blinded, but was it considered for the people who were assessing the outcomes to be blinded?
Vishal?
I was not part of the study, but I can say that death is pretty, like there is no one way about it, right? Like either you are alive or you are dead. So I think that's easy. In terms of brain injury, that's where I think some of the outcome assessment biases can come into play, yeah, especially because here I think we are looking at 36 weeks, various sorts of brain injuries, including intraventricular hemorrhage, ventricular megaly. So yeah, it would be important to look at that. Having said that, I think this is a very large trial across multiple countries and continents. So there are also practical challenges I'm sure Dr. Oi faced in this. So yeah, I'm also looking forward to hearing from Dr. Oi whether there was any discussion or was it even possible to blind the radiologic assessors of the outcome.
Yeah, so of course, blinding would be the best design. And Max Vento did it for some of the smaller studies in the early 2000s, where the people who changed the oxygen FiO2 were the only ones that were aware what the baby was assigned to. But it was not possible to do that to such a large and diverse group of hospitals. There was no way we could consistently maintain strict blinding in so many babies.
I think the question was also about the outcomes, like radiologists.
Sorry?
That the radiologist blinded, or was there any discussion in
Oh,
terms
yes,
of?
of course. Yes, of course. So the people who determine the outcomes, the the statisticians, the head statistician, it was A and B, and then we had IDSMCs overseeing everything. They did not know the assignment of that child.
Thank you so much. Hetal, you can proceed.
Yes. Moving on to the PICO framework, for the population, the study included all preterm neonates born between 23 to 28 weeks of gestational age and required respiratory support at birth, neonates with major cardiopulmonary abnormalities or congenital malformations that could affect the neurodevelopmental outcome or survival were excluded. For the intervention and comparison, infants were randomized to an initial FiO2 of either 30% or 60% using an oxygen blender. The assigned FiO2 was maintained for at least 5 minutes whenever possible. FiO2 was adjusted every 30 to 60 seconds based on the pulse oximetry targets, with a target of 80 to 85% at 5 minutes of life and 85 to 95% at 10 minutes of life and until NICU admission. FiO2 could be increased to 100% earlier if clinically indicated. That is, a heart rate of less than 100 and chest compressions required. For the outcomes, the primary outcome that was considered...
Sorry, Hetal, can I just ask one quick comment? My understanding was that in the trial protocol, once you're assigned to an FiO2 group, you're supposed to maintain it, right? Like for at least first 5 minutes, and then you can adjust it. Is that correct? And the titration was left up to the clinicians, but I think Julie can tell more about that actually people did start titrating earlier.
Yeah. So that was the ideal scenario where you started at one or the other and you kept it for at least a few minutes. But what we found was that the low FiO2 group was adjusted a lot quicker. The 60% group was also adjusted, but at a slower pace. So both needed titration. And it was very important that the clinicians were comfortable with their intervention after the infant was assigned. So we could not, strictly restrict that titration because they would have been concerned. It may have been clinically dangerous. So we are going to do a secondary analysis very soon. We just received funding to look further into our data. So hopefully we can tell you what exactly happened at an individual level very soon.
You can continue, Dr. Wood.
Yeah. Okay. Moving on to the outcomes. For the primary outcome, death or brain injury at 36 weeks of corrected gestational age were considered, where brain injury included intraventricular hemorrhage of any grade, intraparenchymal lesions, periventricular leukomalacia, or porencephalic cysts. And as Dr. Julie said, neuroimaging was interpreted by a blinded radiologist. For secondary outcomes, individual components of the primary outcome, that is all-cause mortality and brain injury, were considered. Some of the predefined exploratory outcomes which were not reported in the trial included BPD, ROP, necrotizing enterocolitis requiring surgery or resulting in death, late-onset sepsis with culture-positive infection, PDA requiring medical or surgical treatment, duration of hospitalization, and neurodevelopmental outcome, that was survival without major disability at 2 to 3 years of corrected age. A question for the mentors would be, why were these outcomes not reported? Are we waiting for a secondary article to follow?
Oh, definitely. When we reported it for JAMA, we were advised to focus on the primary outcomes. So this will come soon.
Sounds good.
And also the last child for neurodevelopment will only reach the assigned age in September.
Yeah, makes sense. As for the sample size, the trial planned to enroll 1,470 infants. That was 735 in each group. It was powered at an 85% power and a 5% significance level to detect an improvement in survival without brain injury from 24 to 32%. The design accounted for 10% non-adherence and adjustment for clustering in multiple births. The sample size was reviewed at interim analysis and no modifications were required. For statistical analysis, the primary analysis followed the intention to treat principle, where stillbirths were included from the primary analysis set. These models were adjusted for key stratification factors, including gestational age less than 26 and more than or equal to 26 weeks, and multiple births. A sensitivity analysis was also conducted across all the randomized infants, including stillbirths. The multiple births were assigned into the same treatment group. A question here was hospital clustering considered as part of the analysis?
Sorry, me again. Yes, so we are going to look at stratification by site. Yeah, that is in the supplementary appendix, I think.
Article. Thank you. So this figure shows the study population randomization. 1,641 infants were randomized, with 827 infants in the 60% FiO2 group and 814 infants in the 30% FiO2 group. Ultimately, after accounting for excluded neonates that were stillbirths and neonates born at more than 29 weeks and neonates lost to follow-up, finally, 728 neonates in the 60% and 741 neonates in the 30% group were studied for primary analysis. Moving on to the results. The baseline characteristics were comparable between both the groups with similar maternal and neonatal characteristics. The mean gestational age was 27 in both the groups, with 33 to 34% neonates less than 26 weeks of gestational age. The birth weight was also similar in both the groups and around 900 grams. For the primary and secondary outcomes, it was comparable between the two groups and no significant difference was observed. Infants assigned to an FiO2 of 60% did have a higher rate of ventriculomegaly, that is 6.4% versus 2.4%, but no group differences were observed in the rates of other types of brain injury. One of the questions was, what do you think could be the reason of higher incidence of ventriculomegaly in the 60% group?
No idea. Probably a chance finding.
Then that was a post hoc inclusion, right, Julie? Was that
That's right.
not part of the initial list of brain injury outcomes?
Never thought of it. Yeah, that's right.
Yeah. So really by chance yeah, interesting.
Yeah.
Another question I had was, here the brain injury-free survival in the study population was around 53%. However, for the sample size calculation, a rate of 24% was used.
That's a
So I
good
wanted
pick.
to know,
So our primary outcome incidence was a lot higher than what we anticipated.
okay.
Yeah, so that's probably something we have to look into when we look at the data properly. So we were not expecting that. About half of the babies met, almost half the babies met primary outcome.
Okay. Moving
think-
on,
Sorry, I was just going to say, I think it's important to remember how the brain injury is defined, right? Different trials define brain injury very differently. I think in this trial, Julie, correct me if I'm wrong, but any IVH, any of these things which are listed, right? Like if they get check mark of one of them, it was counted as brain injury. Also, it was across various countries, various continents. In each of these have sort of different baselines. So I can imagine that it's very difficult before trial to come up with a baseline which is fairly accurate. Because once you start the trial, I would imagine that you still continue to recruit centers.
To your point, Dr. Kapadia, I believe on Dr. Budh's slide about the power calculation, it was the baseline, the estimate was a 24% roughly rate of survival without brain injury, right? So the trial actually found better outcomes than I think what you had anticipated, Julie. Is that correct?
Yeah.
Because it was this is roughly, if you invert the primary outcome here, it's 54% survival or 53% survival without brain injury, when I think the sample size was for 24% survival. So we're actually seeing better outcomes, which is a positive, but does impact how we interpret the findings.
Glass half full, right?
Yeah.
I think that's a good point, and that's one of the things that I didn't allude, because there are some centers which has waiver and some centers without waiver, right? So sometimes you do end up recruiting different sort of population than what you start out thinking that you would recruit. Having said all that, it's a international trial, and difficult to estimate baseline is what I would imagine. But yeah.
So moving on, this table shows the newborn status in the delivery room and on admission to the NICU. It was observed that the 60% FiO2 group did receive less chest compressions, 2% versus 5% in the 30% group, and less epinephrine use, that was 1% versus 2%. And they were more likely to reach a saturation of 80% by 5 minutes, 58% versus 44%, and did have a higher initial saturation as well. It was 38% neonates in the 60% group that needed increase of FiO2 to 100%, while it was 41% in the 30% group. A question here was where the resuscitation practices like the CPAP pressure, delayed cord clamping, the CPAP interface standardized between all the centers before the trial, and how important it is for this standardization for future trials.
No, we didn't prescribe that. We assumed that they would all follow their local guidelines for that. It was impossible to ask them all to do the same thing because they came from very different backgrounds. So there were some units in India, some units in Singapore, Australia. So it was a very pragmatic study.
Okay.
Do you know if any centers in the trial were doing any like intact cord resuscitation, like starting the oxygen on the cord, like before clamping the cord, or no?
No.
Yeah.
But I think it's an important question, although I agree with Julie 100% that when you are starting a trial, it's very difficult to standardize everything across two groups. It would be great if we can, but it's just not possible. You will end up recruiting 100 babies when your target is like 1,600 babies. But it does make you think, right? What we are trying to do is like modulate the oxygen load that a baby gets in the delivery room. And then, as you mentioned, all these things about the practices of cord management, the interface that you use, whether the smallest of small babies are put on CPAP and given a chance versus intubated, all those things do make a difference. But it's great that many of these things are reported across the two arms. For example, intubations seem fairly similar across the two groups. But that's the challenge of doing delivery room trials, sometimes big delivery room trials.
Yes, and this does bring me to my next question about was the need for PPV and intubation compared in these groups with less than 5 minutes compared to more than 5 minutes, and whether we have any data on that?
You mean the reason for intubation?
No, I meant the percentage of neonates in both of the groups needing intubation less than 5 minutes, more than compared to more than 5 minutes?
The timing of
The timeline.
intubation. All right. I think we do. So when we looked, reveal our secondary data, maybe that would be part of the report.
Okay. Looking forward to that. So moving on, this table shows the primary causes of death between the two groups, and this was taken from one of the supplemental files. The question I had here was a difference observed in the percentage of neonates who died in the delivery room?
There were very few deaths in the delivery room. I can't remember exactly what number. There weren't too many at all. It would be part of the report, I think, either the supplementary analysis or the main table. Very few died.
Okay. So this figure shows the changes in FiO2, heart rate, and saturation over the first 10 minutes of life. The FiO2 was very similar between the two groups from around 4 minutes of life, and the heart rate and saturation targets met were also similar in the two groups. A question here was that with the observation, in the first image with the FiO2, the 60% group seems to have a wider spread or a range of FiO2, especially during the early minutes. And why do you think that this variability was more observed in the 60% compared to the 30%?
I don't know. I don't know what the difference is. Remember, this is hard copy recording. We didn't have video recordings to see what the guys were doing in real life, and we didn't have any way to download FiO2 onto an electronic file. So I do not know. This is what was reported to us.
Okay.
I think I'd also just love to hear both of your thoughts, because I think this came up earlier in terms of, what the intervention is actually providing in terms of the differences between two groups. I think it's been alluded to, but you can kind of see maybe a 2 to 3 minute period of difference. Is that what you were anticipating? Less than you were anticipating? More than you were anticipating?
I think we were afraid that it would be like that because there wasn't much of a separation between 30 and 60. But the fact that we found that the lower arm went up faster, I guess was not surprising.
But I mean, if you turn it around the question, right? So right now there is a raging debate, and hopefully Dr. Budh will address at the end as well. Should you do 30? Should you do 60? I think this trial does provide some evidence, some good, high quality evidence in terms of what happens when you start with 30 versus 60% and you are titrating oxygen.
You can
Yes.
keep going.
So now we'll move on to the strengths and limitations of the study. As Dr. Kapadia said, this is a very large randomized controlled trial with a large sample size. It has a high fidelity to randomized interventions, and there was high ascertainment of primary outcomes. The use of consent waiver in many of the centers did increase generalizability. Moving on, every study has some limitations. Here, there was a limited FiO2 range studied, which limited generalizability across all the oxygen strategies. It was not powered for co-interventions like the delivery room practices. Blinding was not possible due to the nature of the study, as we had discussed. There was some protocol adherence variability due to it being a multicentric study. There was oxygen exposure convergence, as we had seen in the previous images, at around 3 or 4 minutes of life. And some of the predefined exploratory outcomes were not reported, which we will be seeing in the next segment. Any comments from the mentors on these?
So we've gone through the limitations already, and hopefully we will provide some results on the predefined exploratory outcomes next year. We are meeting next month to go through them. And as I said before, our last baby will only reach 2 years in September. So protocol adherence variability, I think that's something that we will look deeper into when we dig up the data. And I am not sure how we can incorporate blinding into any future studies. It's so tough. If you want enough babies, it will be so hard to blind. We can't change the gases. That would be ethically impossible. So any comments, suggestions would be greatly welcome because we're planning the next phase.
Yeah, I think blinding is hard, but blinding the radiologist or blinding outcome assessors is a very reasonable strategy. It's also these predefined exploratory outcomes are really important as well because we also want to look at, as you presented in your background about excess oxygen exposure and oxygen toxicity related outcomes. So looking forward to receiving some of those, and hopefully it will be reassuring that there are no differences.
Yes. Moving on to the conclusion, the study concluded that no difference was observed in survival without brain injury at 36 weeks of gestation age between the two groups. The use of higher FiO2, 60%, may show reduced early hypoxia, less bradycardia, and may even reduce the need for advanced resuscitation when compared to the 30% FiO2 group. No difference in major neonatal outcomes were observed between the two groups. Moving on, for the critical appraisal questions. Was the randomization conducted? Yes, randomization was conducted and it was stratified by site, gestational age, and pregnancy multiplicity. Were the groups similar at the start of the trial? Yes, the groups were well balanced between the 30% and 60% groups. Aside from the allocated treatment, were the groups treated equally? It is unclear over here because some of the delivery room strategies like delayed cord clamping, CPAP pressure use, interface used were not reported. Fourth question was, were all the patients who entered the trial accounted for, and were they analyzed in the groups to which they were randomized? Yes. However, we are still waiting for some of the pre-exploratory outcomes, and the exploratory outcomes added post hoc, where the use of cardiac massage, epinephrine, changes in FiO2 in the first 10 minutes, and a specific type of brain injury that was ventriculomegaly. Were the patients and clinicians kept blind to which treatment was being received? No, and as we had discussed, because of the nature of the study, that was not possible. Are the results of the trial valid? Internal validity. Yes, the randomization design did make the results valid, but we're still waiting for some of the hospital clustering data because that does limit the validity. For external validity, it is reasonably generalizable, but the variability in oxygen protocols and monitoring across the centers does limit the broader applicability. Potential to change clinical practices based on study. I would say no, because similar outcomes were observed between both the groups, so more evidence is needed, and still it could be the clinician to decide which would be the initial FiO2 they would want to start with. I would like to hear your thoughts.
Yeah, I think before we move to discussion, I'm just going to launch a quick poll for the audience, and then hopefully... Hetal, can you close
While
your...
people are doing the poll, there was one question posted earlier in the chat by Dr. Muktapuram, which I think kind of speaks to that last point number 8 on the slide right now. So I think it's relevant. He asked, what was the rationale for selecting long-term outcomes such as death or brain injury, given these may be influenced by multiple downstream factors in a neonate's journey, especially when the intervention difference likely lasted only for the first 2 or 3 minutes of life. And I think to add to that, to that last point, I think we have already seen many people taking the data from Torpedo and showing no difference in the later outcomes, but potentially some of those delivery room benefits. And people have been talking about maybe it should change practice, that maybe we should have this sort of 30-60 like stepwise approach to the smallest babies. So it seems like maybe people want to use shorter term outcomes in this situation to sort of influence a practice change. So I'd love thoughts from both of you about like what's the right primary outcome for these sorts of trials to really show a difference that's good at change practice.
So we've seen probably with increasing alarm, the rapid revisions of many guidelines around the world. And that's pretty concerning, because I agree that there is no hard, definitive evidence that using 30 or 60% changes clinical outcomes. It may confer physiological stability within the delivery room, and there is quite an increasing body of evidence, for example, from the Dutch group to show that higher, maybe starting on higher, may achieve better clinical stability at delivery. But we are still lacking evidence for harder outcomes later on. I think at the moment, we watch with interest about what is happening around the world, and hopefully the next phase of the study to provide some definitive evidence for practice will not take as long as this study. Vishal?
Yeah, so I think it's a very important question, very existential question for some of us who are trying to study delivery room resuscitation, in terms of what outcomes should you actually choose when you are trying to do this trial, and more importantly, change practice, because ultimately you don't want to change practice if it is not, the practice changing outcomes is what we are trying to do clinical trials for, right? So then if you look at the ILCOR, I think Dr. Strand published in 2020 sort of ILCOR thinking in terms of what would be practice changing outcome. And that paper, if I find, I can put it in the chat, but it talks about critical outcomes, important outcomes. It sort of divides outcomes up accordingly. And then based on the critical outcomes, usually when ILCOR body sort of sits down and decides whether it should affect the practice, then those are the outcomes that are talked about. I think this is a very, very important critique that could first few minutes of life, if you do something small, could it change outcomes such as death, brain injury, because it is so distant from the intervention, and intervention is done for such a short period of time. I would say that the debate is still ongoing. I would not be comfortable changing my resuscitation practice based on early physiologic outcomes, which may be related to illness severity and may have nothing to do with the intervention that we are trying to do. We have a long history in neonatology on jumping gun on some of these interventions, which were beautifully working in animal models and simulation models and short observational studies. When large studies were done, either they were found to be not useful or harmful. Sustained inflation comes to my mind, which is something that a lot of centers outside of US were practicing routinely. And I think the SAIL trial was something that was very interesting. So that's what I would say, that I think we'll continue to plan our trials based on outcomes which are clinically important, but at the same time, we will not ignore a lot of short-term morbidities. And maybe it points out to some of the new things that you are seeing in neonatology, as maybe it should be like ranked outcomes we need to look at, and we need to look at the intervention as a whole rather than just putting all of our money on single primary outcome, which was decided based on tradition rather than physiology.
I think Praveen has his hand
Yeah, go
patiently.
ahead, Dr.
He's very polite. Very
Well,
polite.
thank you so much, Dr. Oe, Dr. Kapadia, Dr. King, and Dr. Jain for encouraging our fellows. I mean, I have to say that you've done a commendable job. We can critique all that we want, but you guys have done so much job that we are open to discussion at this point and doing more studies. Your systematic review and meta-analysis of saturation of 80% and a heart rate target of 100 gave us insight as to what we should target in physiological studies, just like how Dr. Kapadia had mentioned just now. And so I think there is relevance, and there are moving forward, targeting oxygen saturation would be something that will be great. And it opens up a whole can of worms saying that how are we titrating oxygen? The saturation is now at this point based on AAP and RP at 2 minutes, correct? So that's what we have done in animal studies as well. So, and we found that lambs that don't achieve saturations of 80% and target heart rate of 100 don't do well in first 2 hours of life. So you have given us an entire valuable data for us to work on. So we
We
commend
can
on
retire
that.
now.
Yeah, you can
Let's
definitely
go,
retire.
Vishal. Let's go, Vishal.
What time is it in Australia right now?
Oh, too early.
It's not too early, but
It's too early. It's too early.
yeah. So, I mean, this is a great study that you've done, especially the systematic review and meta-analysis with the grading of whatever you have done, you and Vishal, and along with Dr. Vento and everyone else, including Dr. Satyan, who has done all these things. It opens up our mind to answer these questions. And so that's where this starts. Delayed cord clamping and effective resuscitation in a baby with a heart rate of less than 100 is still a bigger question, but 18 times higher risk of mortality with a baby born with a heart rate of less than 100. That's kind of like an amazing finding that you guys presented. So thank you for that. And thank you for encouraging our fellow.
Can I ask one more
Thank
question
you.
if there's time in terms of we've talked about like what's the best primary outcome. I'm also curious if you guys' thoughts about what's the best intervention or combination of interventions. Vishal, you're here, so we could, instead of FiO2, is it the saturation targets? Or if we think about different study designs, like what about, a factorial approach where you start combining things, or is cluster randomized trials the way that we should be going, which helps with some of the consent issues, et cetera?
Yeah, all of it, right? So, Brian, to be honest with you, I think it's important. So, what Nat Motion and some of these other studies looked at was there was a difference, although very fragile difference, with a credible interval crossing the or almost crossing. So, between low versus high, right, which allows you to give a reasonable separation. But I think what one of the mistakes that I feel that our field is making is separating these two things out. Initial FiO2 and then do whatever you want, right? After you set your blender versus actually titration. So I think titration is equally important in terms of the oxygen load that you end up delivering to a newborn. And this is my biased opinion. I'm plugging in for my control trial that I'm doing, which is looking at different oxygen saturation targets. But I think it's important to, I think combination of those would be great. Factorial trials are amazing, but this is not a pure two different because it affects. So the sample size really balloons up very quickly when you are trying to do those sort of combinations. I think cluster randomized control trials are great, but at the same time, you have to ask yourself a question whether an institutional consent versus individual consent, that question comes up. I think EFIC is going to be very important in US. And I think George and some of the other people are looking at that and how we can move some of these trials forward. You mentioned sliding scale, which I think there is a paper which is, I think, in preprint right now, a small paper in Journal of Perinatology, which is undergoing review. So not peer reviewed, but I came across it, which is looking at some of these different FiO2s and aggressive titration, which one of our polls said that we should titrate aggressively. And that paper showed that if you too aggressively titrate, you will end up with very high saturations within first few minutes of life. Is that good? Is that bad? I don't know, but I think you have to keep that in mind. And putting my NRP hat on, sliding scale sounds great on a piece of paper, but when you have a baby in front of you, and if you have like 7 groups gestationally divided into 4, 5, 6, 7, and trying to choose right FiO2 each time, that is also going to be a little bit of cognitively challenging. If it works and it is needed, then it can be done. But if it doesn't really impact outcome, then I think keeping guidelines simple is better.
Yep. Thank you so much,
Any last
Vishal.
words,
And
Dr. Ray?
just going through the poll, which you're correct, like 75% of our polling audience do prefer aggressively titrating upwards, but as you said, they may not be the best approach. So a lot of questions still remaining to be asked, and so a lot of trialists who are in the audience have a lot to work on until Julie decides it's time to retire now because she has helped Praveen so much. Anyways,
Oh, we got a house in Bali we could
yeah.
go to.
Yeah.
Yes, we are planning the next phase.
Yeah.
So any comments, suggestions, more, please feel free to contact me. I know around the world, many of the societies are changing their recommendations based on net motion and torpedo 3060. I would urge caution and urge some, it's back to 2006 again, isn't it? Flipping around. Yeah. So very, very just watch this space. Hopefully you can join the next part of the trial.
So we're about to take any closing comments. Vishal, you have any final comments for our trainees in the audience?
No, I think very well done. I really loved the way Dr. Budh sort of critically analyzed the trial, brought out the limitations, and I think the discussion was fantastic. As Julie said, I think this is still an open question, but I think we are chipping away gradually at this particular question, and hopefully in coming few years we'll be able to say that this is what you should do definitively. But my comment to trainees is always keep your doctor's hat on when you are resuscitating babies. There are trials, and then there is a baby in front of you. You have to evidence-based medicine is basically looking at your best evidence, values and preferences, and putting them together. Thank you.
Yeah, well, thank you so much, Hetal. This was an excellent presentation, very well reviewed, echoing Dr. Kapadia's thoughts. And thank you, Dr. Oi, coming early morning all the way from
Oh, it's
Australia.
not
We
that
woke
early.
you
It's
up
okay. It's okay.
to helping us. It was great to all the trainees for you to learn from it. This will be our final session of the current season. We'll wait for our new fellows to come in, and we'll be back again in August for our next seasons. Thank you, everyone, for joining in. Thank you so
Thank you
much.
for having me. Bye-bye. Well
Thank
done,
you,
Hetal.
Dr. Budh.
everyone.
Okay.
Thank you,
Thank you.
everyone.
Bye. Bye.
Bye.